So I remember going to one job. It was a 6-year-old. He was 9 days after a tonsillectomy and he was filling bowls up by the minute. His parents took me to one side and said, please don't let our son die. Our daughter's already died. Now, I had a lot of work to do. He was already very poorly, but this information really impacts you as a clinician. Thankfully, we managed to get him into surgery just in time. Unfortunately, we weren't able to say the same for 2 children that we lost in an RTC. At least the road's been changed and the speed limit's been reduced. But there are some not so good days. There are better days. I've delivered babies in the back of an ambulance, the side of the road, you name it, we've probably been there. I've been to beaches, I've been to brothels, I've been to mansions, I've been to woods, I've been to council estates, I've been to football matches. It's a great job. But actually the reason I'm here today is to talk to you about the other side of my job. It's those patients that don't know where to turn to in the middle of the night or in hours, but they're just, for one reason or another, not contacting the services that they need to. So they call 999. Patients like 80-year-old Margaret, who's got COPD, probably calls us every other month when she has an exacerbation. She's well overdue an asthma, a COPD review and a medication review, but actually getting in touch with a GP surgery just feels like too much hard work. It's patients like 78-year-old Agatha, who's been given a palliative diagnosis, but not all the information that goes with it. She doesn't know what services are available, the family are a bit confused by the whole process, and when she starts feeling symptomatic at 3 o'clock in the morning, they all panic and they call us. And that's fine, but there are much better services available to help and support her. It's patients like 36-year-old Dave, who's got a tracheostomy with a minor blockage that really the carers should be able to deal with, but they panic and they call us. Again, all fine, but actually with a little bit more support, training and community resources, all these patients could be managed in a different way. And this is when I realised that if only I knew more in terms of signposting and supporting and clinical excellence, then I could do more for my patients. And thus started my journey into advanced clinical practice. Now, what does this mean, you ask? Well, it's a master's education that any allied health professional nurse can undertake. So an OT, a physio, a nurse, a paramedic, anybody can do, which gives us the same base level of education. There are 4 pillars to advanced practice. There's education, there's research, there's leadership, and there's clinical. Now, this is like a toolkit, so we all understand how to develop and excel in these areas for our own area of practice. So what did that look like for me? Well, I decided that in order to be an efficient advanced practitioner, I probably needed to go into primary care and understand how they made their decisions, how they did it over there. So I joined primary care in 2017 and quite quickly realised that I was much better in the community side of things than the surgery setting. It is very difficult to get a patient to actually leave your room, particularly when you're running late. I'm so used to getting up and leaving and getting back into my big yellow bus that it's an art form all on its own. I remember seeing an ingrown toenail and thinking, what do I do with that? It's not hanging off. So there was a very steep learning curve. But actually, playing to the skill set of a paramedic, I was able to go out and do the bulk of the home visiting. So there we were able to look at the holistic picture around the patient, their home, what they needed, and this helped me build a really good contact list. So I had the duty social workers, the OTs, the community therapies, district nursing, the enhanced support teams, all on standby to be able to navigate this community-based system to help actively avoid admission for these patients and keep them safely at home. Mainly because I knew what their journey would look like. I knew it would probably involve an 18-hour wait outside the back of the ED on a big yellow ambulance, then probably a 2 or 3 day stay in an A&E department, then a further 8-week stay on a ward somewhere, then maybe into a community rehab hospital before being discharged home, where they've massively deconditioned and a shell of their former selves after going through all that experience. Actually, if we can help them get better at home and avoid hospital altogether, that is the gold standard. So then I started picking up the care home and nursing home ward rounds. So this was a caseload of around 410 patients that I could keep a sense check on weekly. And this was a great way to learn about complexity, frailty, chronic conditions, palliative care. And my learning curve again grew massively. But it was also great from prevention and admission avoidance. And actually engaging with families on a weekly basis and helping them navigate the healthcare system and the complexities and the journey for their loved ones, or for the patients themselves or the staff. So it was a really good kind of check-in sense point that could happen, and something that was so different to my experience on the ambulance, turning up at 3 o'clock in the morning and having to provide the really emergency side of the care rather than the planning. And it felt that by doing this, I was actively avoiding my colleagues going at 3 o'clock in the morning, because patients felt empowered, educated, supported to have these community-based management plans and knew what was happening and the trajectory of what to expect as well. So an element of the job I really, really enjoyed. Now, something else happened as well during this time, and I realised that not a week went by really where there wasn't a form I couldn't fill out, or a policy that wasn't written for me. And so in a way, I became a bit of an accidental leader. I had to link in with meds management because suddenly paramedics could prescribe. I had to change policy on different things and fly. And it was a really interesting, different journey, again, supporting my leadership pillar of advanced practice, but actively helping change the system, not just for those coming after me, but for my profession as well. So it was a case of being right place, right time, but a lot of really important changes I felt were made for the future paramedics, but working in primary care as well. So when an opportunity for clinical leadership came back up in my organisation, I thought I'd give it a go. I'd take the learning that I'd had from primary care and bring it back into the ambulance sector. Now, I had a lot of ideas. I banged on a lot of doors, and interestingly, a role was created, the professional development lead, with a specific focus on advanced practice, which I was successful in getting. So this now meant I had a national portfolio of sorting advanced practice out for everybody. All paramedics working in the Welsh Ambulance Service, I should say. This was great. This was exactly what I wanted, but it was also really big. And I came in at a point where there was already an evaluation going on for a pace setter project. So they had, again, decided that rotating paramedics into primary care was the place for us to learn. And this happened in BCU. And the website, www.apppacesetter.co.uk, has all the information on the evaluation, which is a great source of great starting point if you're interested. What this showed us was that when staff train and work locally, they understand how the local pathways, community options that are available for those patients are, and we can help navigate admission avoidance, community pathways, strategies to help keep patients safely at home and in the community, and wrap the resources around the patient, particularly in that 24-hour space when resources and services are really limited. So it's a really important learning journey, that access to primary care and that understanding of the system, the infrastructure, helps us with the same patient group in that sort of unscheduled emergency 24/7 environment. So this is my plea to you. If you are part of a community health board, a primary care sector, and you want to know more, then please get in touch. We are growing our numbers. We have rotational models operational throughout every health board in Wales, but we're expanding, and we are looking for strategic collaboration and to help unify this at a much more strategic level. So currently we've done that with BCU and with Health R, but if you're part of the other 5 health boards and you want to really think about where the advanced paramedics are, where you'd like them to be for the future in terms of retention and growth and training capacity, then now is the time and this is the place. So please get in touch. I'll provide my information at the bottom. Thanks very much for listening. Cheers. Bye.